Hello, it's a great pleasure to be able to talk again at the Limits meeting in Brazil. My name is Elliot. I'm a professor of cardiovascular medicine at University College in London and a consultant cardiologist at St Bartholomew's Hospital. And today I'm going to be talking about some of the recent advances in the diagnosis and management of cardiac amyloidosis. These are my disclosures. So amyloidosis is a disorder of protein folding. Protein folding is one of the fundamental elements of how proteins work. And normally within all cells, there is a tightly controlled balance between protein synthesis and protein degradation. When this system fails, one gets accumulation of misfolded proteins or protein fragments. Cardiac amyloidosis is the process by which these abnormally folded proteins assume a common conformation, forming a polymerized structure with these characteristic helical fibers, which then deposit within various tissues. Here you see an example of that in the heart. So in the top left-hand panel, you see an H&E stain of a cardiac tissue from a patient with amyloid, and you see this amorphous substance between the cardiomyocytes. In the bottom left-hand panel, you see this characteristic change under polarized light called apple green birefringence, which is highly characteristic of amyloid fibrils. Importantly, whilst the structure of all amyloid fibrils is the same, the precursor proteins vary considerably. And there are many different proteins that can misfold or dissociate to cause amyloidosis. In the case of cardiac amyloidosis, there are two main forms that account for more than 90% of all cases. The first is AL, or amyloid light chain amyloidosis, which is caused by the production of excessive light chains from a plasma cell dyscrasia and deposition of these light chains within the heart. The second and more common form results from the deposition of a normal transport protein, transthyretin, or what used to be called prealbumin, which is an important protein responsible for the transport of thyroxine and vitamin A. And this protein is produced from the liver and again becomes deposited within various tissues, including the heart. The process of amyloid formation in ATTR amyloid is thought to relate to dissociation of the native protein. TTR is a tetramer, and it's thought to be dissociation into its monomers and other fragments that is the first step in amyloid formation. And this is relevant with regard to therapy, which I'll return to later in my presentation. TTR amyloidosis also occurs in different forms, and there are both familial and non-familial types. In the familial form, caused by mutations in the TTR gene responsible for transthyretin, this is a multi-system disease which can present throughout the life course with neurological manifestations, involvement of the kidney, of the liver, of the eye, and the heart. The pattern of disease that we see is to some extent determined by the underlying mutation. And in some cases, we see variants that result in a purely neurological phenotype. This, for example, is commonly seen in the V30MET mutation, which occurs endemically in Portugal. Other variants are predominantly cardiac, and some result in a mixed phenotype. With regard to the cardiac variant, the commonest genetic variant that results in cardiac amyloidosis is the V122I. And this occurs with a frequency in people of black African descent, particularly from West Africa, in about 3 to 4%. Not everybody that has this variant develops cardiac amyloidosis, but this variant is clearly overrepresented in many heart failure populations. To the cardiologist, amyloidosis will present in one of two scenarios. The first is in its familial form, and this has a variable age at presentation, has a male predominance, and often presents in association with neurological manifestations, and in particular, familial amyloid polyneuropathy and dysautonomia. Much more commonly, we see an acquired form, also called senile or wild-type ATTR, which is nearly always a disease of the elderly, again with a male predominance. And here we see manifestations largely confined to the heart, with the exception of carpal tunnel syndrome and less commonly biceps tendon rupture. In textbook descriptions of cardiac amyloidosis, one of the cardinal features is said to be the low voltage ECG with pseudo-infarct pattern. And this is certainly true in many patients and often occurs in association with conduction disease and atrial arrhythmia. But I think it's important to appreciate that the low voltage ECG is actually a relatively late manifestation of the condition. And the presence of left ventricular hypertrophy or normal voltages on an electrocardiogram does not rule out the possibility of amyloidosis, as in this example. With regard to what we see when we take pictures of the heart, it's reflected in the underlying pathophysiology as shown on this slide. So in each of these panels, you see the consequences of amyloid deposition in the top left, concentric left ventricular hypertrophy and right ventricular hypertrophy. In the bottom left, you see infiltration here of the interatrial septum. And on the bottom right, you see infiltration of, in this case, the mitral valve. So when we perform echocardiography, we see exactly the same picture. We see concentric left ventricular hypertrophy, sometimes associated with a small pericardial effusion. Again, another cardinal feature of this condition is said to be restrictive filling on a cardiac Doppler. And this certainly can occur, as in this example, but is present usually in only 20 to 30% of patients. Again, some examples. Here you see concentric left ventricular hypertrophy in the short axis view on the left and in the apical four-chamber view on the right. Please note here that the ejection fraction, as calculated on this image, is probably within the normal range because of relative preservation of radial function. Whereas you can see in the right-hand frame, the long axis function is significantly impaired. Moreover, one can see regional differences in deformation, and this picture is highly characteristic, although not entirely specific of amyloid. And this is where you see the so-called apical sparing pattern, where longitudinal strain at the apex is relatively preserved compared to other segments. Now, with regard to amyloidosis, I think there are three major drivers of change, and the first of those is improved diagnostics. With regard to the detection of amyloidosis, we have the electrocardiogram, which gives us indirect measures of infiltration, the small voltage. In some instances, particularly in TTR amyloidosis, there may actually be a hypertrophic response, and this is responsible for the large voltage that we see in some people with amyloidosis. We see the consequences of amyloid deposition in increased wall thickness. And now with cardiac MRI, we can directly interrogate the interstitial compartment and demonstrate infiltration and increased extracellular volume. As I'm going to show you, one of the biggest advances we've had in recent years is our ability to specifically image amyloid fibrils themselves. So here you see a typical MRI in someone with cardiac amyloidosis, very similar to the echo I've already shown you, with concentric left ventricular hypertrophy, atrial dilatation, and right ventricular hypertrophy. But the major thing that MRI brings to the table is its ability to show this dramatic expansion of the extracellular space, where one sees often diffuse hyperenhancement with gadolinium contrast agents, and often patterns such as this with this characteristic subendocardial distribution. MRI can show us pictures which are highly characteristic of amyloidosis, but as yet it cannot distinguish between the different types of amyloid. And that's where this second test comes in. This is actually bone scintigraphy. And it was noted many years ago, serendipitously, that some patients undergoing bone scans seem to have increased cardiac uptake of the bone tracer. And we now know that this is a highly sensitive and specific marker of TTR amyloidosis. And you can see in this example here in panels C and D, in a patient with cardiac amyloid, this intense uptake of this bone avid tracer. And the sensitivity and specificity of this technique is such that we can now develop a diagnostic algorithm which is no longer dependent on endomyocardial biopsy as it was until relatively recently. So if one has an echo and/or MRI which is suggestive of amyloidosis, if one then performs a DPD scan, a bone scan, if that is negative, then it is extremely unlikely the patient has TTR amyloid. One should then seek light chain amyloidosis, and in particular look for light chains in blood and urine. If this is negative, then it is unlikely the patient has AL amyloidosis. The major remaining indication for a biopsy is in those patients who have a positive DPD scan and evidence for a plasma cell dyscrasia, and in those instances, a tissue biopsy is usually required to distinguish between the two. Very interestingly, there are now new PET tracers that were developed for the detection of amyloidosis in the brain. These are based on, they will have a common structure which is based on thioflavin T, which is an amyloid avid dye. And these seem to specifically bind to amyloid fibrils and are showing great promise in the early detection of amyloidosis. They also allow quantitation, and there's now some suggestion that it may be possible to distinguish between AL and TTR amyloidosis on the basis of the kinetics of the tracers. The second driver for change is what has occurred really as a result of the application of these new diagnostics, and that's an entirely new epidemiology. Until relatively recently, I think it was generally felt that amyloidosis, cardiac amyloidosis, was a rare disease. But as you can see here with this number of patients diagnosed at the National Amyloid Centre in London, there is now a dramatic increase, particularly in the diagnosis of wild-type amyloidosis. If one takes populations such as, in this instance, patients with a clinical diagnosis of heart failure with preserved ejection fraction, you can see here in this study using bone scintigraphy, 13% of these individuals had evidence for TTR amyloidosis. And we're seeing similarly high prevalence rates in other scenarios. For example, in patients undergoing TAVI for aortic stenosis, 16%, or even patients undergoing surgical aortic valve replacement, 6%. So it is very clear that there are a large number of undiagnosed patients with amyloidosis. But perhaps the biggest driver for change is the fact that cardiac amyloidosis is now potentially a treatable disease. I'm not going to talk about light chain amyloidosis, other than to say that it is critical if you have a patient with suspected amyloid that you try to exclude AL amyloidosis at an early stage. Survival in AL amyloidosis is critically dependent on the severity of the disease at diagnosis, and delayed diagnosis by as much as 6 months can make the difference between survivability or death. Patients with light chain amyloidosis are treated with chemotherapy, and if caught early enough, survival rates have dramatically improved. For TTR amyloidosis, we now have a number of different therapeutic approaches that are being explored. As I've said, TTR is produced from the liver, so historically, particularly for familial amyloidosis, the only treatment that was available was liver transplantation. But we now have drugs that can knock down TTR production within the liver, drugs which stabilize the TTR tetramer, and there's now increasing interest in drugs which can potentially deplete amyloid fibrils within the heart itself. Of these approaches, one has been subjected to a randomized clinical controlled trial, and this is a drug called tafamidis, which is a TTR stabilizer. And in this population of patients with TTR amyloid, there was a 30% reduction in mortality, which to my mind remains pretty amazing when you consider that the median age of this population was 75. Importantly, this therapy is not designed to reverse the disease, it's designed to stabilize the disease, and we certainly saw stabilization in terms of symptom class as well as in functional capacity as measured by 6-minute walk test. And we also saw reductions in hospitalization. An alternative approach is to prevent TTR production, and this is now being achieved in patients with familial amyloid polyneuropathy using RNA technologies such as antisense oligonucleotides or small silencing RNAs. And both of these techniques effectively interfere with gene transcription and prevent TTR production from the liver. And there are now ongoing trials using these agents for the treatment of cardiac amyloid, but already we have a suggestion from trials in neuropathy that one may see stabilization or even some suggestion of reversal of the cardiac phenotype, as you see on this slide, with a reduction in BNP during the course of this study. There are in development drugs which are designed to clear amyloid from the heart. And most of these are based upon monoclonal antibodies that bind either to TTR or into serum amyloid protein, one of the key components of all amyloid deposits. These are in phase 1-2 trials at the moment, and we await the results keenly. But something which I think until relatively recent, which was science fiction, here you see the ability to actually alter gene expression directly through gene editing. And in the study recently published in the New England Journal in 6 patients, here exploiting the CRISPR-Cas technology identified in bacteria, we can introduce through using lipid nanoparticles injected into the circulation a TTR gene sequence as well as a gene sequence which allows production of Cas9 within cells. This is taken up within tissues by endocytosis, and then the combination of the subsequently translated Cas9 protein with the guide RNA is then incorporated into the nucleus. And then this system then introduces a break within the TTR gene, which is a permanent reduction in the TTR gene function. And you can see on the right dramatic reductions again in the amount of TTR circulating in. So I think that the message really is that TTR amyloidosis is significantly underdiagnosed in clinical practice. It is increasingly important to make the diagnosis, both of AL amyloidosis, which is already treatable with chemotherapy if caught early enough, but increasingly I think we will be identifying patients with TTR amyloidosis who we can stabilize and potentially treat and reverse at least some of their disease in the future. I leave you with this ancient paper in 1964. It's actually one of those classic old pathology papers. And this statement, I think, unfortunately, until relatively recent, has remained true, in that the diagnosis of amyloid by clinicians and by pathologists has been frequently overlooked. I think with the technologies we now have available, that should no longer be the case. Thank you very much for your attention.